Hi Bio4, welcome to part 7 of respiratory chapter, and we're now moving on to the mechanics of breathing, how it is that you get air into your lungs and how do you get air out of it. So when you first start thinking about this, you kind of think that you suck it in and that's how you get air in your lung, without really thinking of the partial pressures that have to exist for that air to move. So as a definition, inspiration is the movement of air into the lungs, expiration is the movement out of the lungs, and we have muscles that are involved in this because they have to change the pressure of that air inside the thorax. So imagine a balloon that's filled with air and you squeeze it, it does have an exit. You're able to make that balloon smaller, increase the pressure, and the air is going to go out. Correct? Now, if you could decrease the pressure in that balloon, and then the pressure outside of the balloon would be greater, air would move in. So we need muscles to do this. We need muscles to be changing the size of that box, which is your thorax. The muscles that are going to do that are the diaphragm. So think of that as the lower part of the box. Right, that can come down, and your intercostal muscles that are sort of the sides of the box, muscles close to the ribs that are going to be able to sort of lift out. So if those ribs were to lift out and the diaphragm goes down, all of a sudden you've increased the size of the box. And if you've increased the size of the box, you've diminished the pressure inside that box, and air is going to want to go in. So let's think more about this. So inspiration then, contract the diaphragm, bring it down, make the box bigger in the inferior portion, elevate the ribs, thoracic cavity is enlarged, and the last thing that happens is that air flows in. So this, if you've never thought about it before, you think it's the other way around. You think air flows in and therefore the size of the thoracic cavity is enlarged. It's not that way. You first enlarge the cavity, and the result of that is because of the lowered pressure, air is going to flow into it. This is in a diagram where you have these intercostal muscles that can actually lift this a little bit. You can elevate the ribs here, and then this box on this side of the box has become larger, correct? And the diaphragm is usually quite curved like this, and what you're going to do is flatten it out, and you've again increased the size of this box. Okay, I really like the picture here. If you've ever used one of these bellows for a fire because you want to give it more air, this is such a good description of what your lung is doing. So you put your hand on both handles and you open up the handles, you make that box larger, and the negative pressure inside it makes air go into the bellows. And then you squeeze them tight, you increase the pressure in there, you make the box smaller, and the air shoots out. And that's exactly the way you breathe. Okay, so the trick then is being able to enlarge the box and diminish the box. And how do you do that? So expiration is a little different because all you have to do is actually release what you did during inspiration. So if you use these muscles to enlarge the box, now you're just going to release those muscles and the box will just elastically return to its position. So releasing the diaphragm and depressing the ribs is going to allow you to increase that pressure and release that air back out again. So size of thoracic cavity reduced, and the outcome of that then is air is going to flow out. And you know that in a balloon, if you have a full balloon and you don't tie it and you release it, that pressure inside the balloon is greater. It's going to shoot out of that balloon very quickly if you don't tie it at the other end. So just remember that exhalation is mostly passive. Okay, it's the release of those intercostal muscles. The diaphragm then is going to go back up to its domed position. There are some muscles. Sternocleidomastoid actually is also sort of bringing this all up a little bit and making it bigger. So these are the main muscles I'm mentioning. There are others involved, but we're just going to keep it to those. These are some of the other ones. So sternocleidomastoid is shown here, your scalenes. You don't need to know all these. Here are the intercostals, and here's a really nice diagram of the diaphragm. So it's very domed, but you can actually bring it down quite a bit. Look at this. Rectus abdominis is also part of it. So we use a lot of muscles to breathe. Okay, what about the control of the automaticity? So you want this to happen without you thinking about it. It's automatic, and it's coming from the brain stem. So we have some receptors that are going to be receiving input as to, are you low in oxygen or are you not? Do you need to be breathing more, or is it okay to be breathing less? So these respiratory centers that are in the brain stem and the medulla oblongata are going to receive input. They're going to receive input from peripheral chemoreceptors, determining what's happening throughout your body. Central, which is brain and brain mostly, not stem as much. Stretch receptors and irritant receptors. So stretch receptors, if you've inflated your lung, it's going to start firing saying, okay, this is inflated, now let's go the other way. And an irritant receptor, can you imagine what that is? It's inhaling some terrible dust that went into your lung and you just automatically start coughing, which is you start moving air out of the lung. So these respiratory centers then are monitoring. They're monitoring all these things. They're receiving input. And they are monitoring how? They're responding to changes in pressure. P is pressure of carbon dioxide, pressure of oxygen, and also what the pH is doing. pH of the blood is doing. Are you in acidosis? Do you need to be breathing more? So these chemoreceptors are crucial as to where you put them. Where are they found? Where will you put these if you need to monitor? It's like if you're monitoring CO2 inside your house, where would you place it? It's the same. In a human, if you're monitoring that, where would you place the receptor? So we want to place it in crucial places where we know what the blood is doing. So if we put it in the aortic arch, we know that that's blood that is exiting the left side of the heart and going to the rest of the body. It's the blood that's distributing, right? The distributing blood to the rest of the body. Is it adequate? Is it not? And then where else? Well, we want to know the distributing blood that's going up to the head. So these are carotid bodies, and we're going to put it on the carotid arteries. So now we've monitored everything going out of the left side of the heart and down, and everything coming out and coming up. So we've essentially covered the whole body. For locations here, aortic arch, right? Blood's coming here to the rest of the body, and carotid bodies. They're monitoring blood that comes up to the head and the arms. And the vagus nerve here is monitoring. Very important. Okay. So what do these central chemoreceptors do? If it's central in the brain, they do what? They respond to something else. They respond to pH changes in the cerebrospinal fluid. Very sophisticated. They're measuring that CSF all the time. And those receptors are found in the medulla oblongata also. And cerebrospinal fluid is floating in here and coming down. So the medulla is going to be able to monitor that pH change. Stretch receptors, they're going to inhibit the overinflation. You don't want to inhale so hard that you start damaging little arteries. So you don't want to overinflate. And these are found in smooth muscle. There's smooth muscle of the bronchi, the bronchioles, and of the pleura itself, of the actual coating on the lung. So we are monitoring all those entryways coming into the lung. Irritant receptors, I mentioned. What do they do? Well, they respond to nasty stuff, to smoke, to dust, to pollen, actually to cold air also, to You know that someone with asthma is out in the cold air and they start coughing. So they communicate with the dorsal respiratory group, which is found on the medulla. And you can cough, you can bronchoconstrict to stop more of this coming in, you can hold your breath. All these are reactions to those irritants. And where would you put those? You would put them in the epithelia of the airways. So all these airways are coated by these receptors that are able to detect some of these nasty stuff, some of the pollen and dust. I know pollen is bad right now. One last thing here is another way that we move air, but it really isn't respiratory, is when we do things like laugh or cry or gasp. We're really moving air, but we don't think of them as respiratory movements. So these are affected. You can do them consciously. Of course, you can laugh and cough and do all these things on command. They also are triggered by the limbic system, which would probably be, triggering emotions like laughing and crying. And they travel down the tracks. We didn't talk a lot about these tracks. These are the freeways, I call them freeways, down the corticospinal tracts to the respiratory neurons in the spinal cord. So you need to tell the respiratory neurons that you need to breathe, but they totally bypass the brain stem. It's very interesting. So these integrating centers then, brain stems, central chemoreceptors. You don't need to memorize these. I just wanted to give you a visual of how the brain stem is where these integrating centers are found. We have very little left, so I'm going to tag it onto this last video about some pathologies of the respiratory system, emphysema, and chronic bronchitis. So in emphysema, the alveoli that you think of, the grape-like structures, become enlarged because some of those little grape-like walls break. They become brittle and they start to break. So if you have two that were side by side and they've broken, now they've become one. Often with inflammation that goes on for too long, smokers as an example, it can promote fibrosis, which means you've attacked the wall of that alveolus for too long. And so fibrous tissue forms in a protective manner to try and protect that layer. And then, of course, if there's fibrous tissue, it doesn't absorb oxygen as well. The airways could potentially collapse during expiration. This is an advanced emphysema. Often patients use a large amount of energy to exhale because it's harder to exhale from a grape cluster that's just one than little ones with their bronchi that are leaving that region. So it's a difficult breathing. And in advanced emphysema, cyanosis could appear, which is looking blue, and this would be very advanced. Sometimes also you see barrel chest. Barrel chest is an individual who seemingly is overinflated and can't let go of that extra air. And that's an example of it. There's a picture of it. Barrel chest. In chronic bronchitis, this is the mucosa of the lower respiratory passages become inflamed. You have too much mucus. So if you're releasing too much mucus and there is inflammation, what's going to happen is there's a narrowing of that airway. So the pooled mucus is also going to impair ventilation. And this is a really good environment, nice and warm, full of mucus, for infection to thrive. So pneumonia could occur. and then hypoxia and cyanosis again in very advanced cases of bronchitis. So just think of it as inflammation of the bronchi. They become enlarged, the airway is diminished in size, and there's too much mucus, and infection can start. As far as aging affects, the elasticity of the lung decreases, and therefore the volume of air inhaled decreases. We can measure this really well. In our physiology class, we can measure how much volume of air you're moving when you breathe and the maximum capacity of air that you have to inhale. So when that volume is decreased, blood oxygen levels obviously decrease along with it. So those stimulating effects of carbon dioxide decreases also. So you're breathing less, more shallow breathing also. And again, greater risks of respiratory tract infection. These are just some review slides for you to remember what was what and which of these cells in the alveoli. I'm going to end it right there for the end of this respiratory chapter. Thanks for joining.